Hello, everyone. I'm Jim Garrison, and I want to welcome you to day 283 of Humanity Rising. Over the past year or so, as we've been holding our Humanity Rising sessions, we've emphasized the question of health. We've had probably a dozen sessions altogether on various dimensions of health during a time of a pandemic that has challenged people and nations and communities all over the world with how to maintain healthy systems as a bulwark against disease. And once those systems break down, how do you regenerate them? In this case, in the face of a little virus that has demonstrated a remarkable adaptivity and energy and intelligence in shape-shifting into different variants and is still now with us. So today, once again, we're going to look at the issue of health and examine one country, the country of Ethiopia, actually, as they grapple with many of the same issues that countries all over the world are grappling with in our time. Before we do that, let us take a moment to just pause, as we do at the beginning of every one of our sessions, to just take a few deep breaths. Center yourself in your body. Become aware of your heart. And for the next minute and a half, attune yourself with your heartbeat in a spirit of gratitude and deep thanksgiving that you're alive. We're all alive at this most extraordinary moment in the human journey. Thank you, everyone. And now, with an open heart and a heart full of gratitude and love for each and every one of you who are joining our session today, I would like to welcome my very good friend and colleague, Dr. Peter Mary, who's going to moderate our program with the former Minister of Health of the great country of Ethiopia. Peter?
Great. Thank you, Jim. And good to be back. Yeah, and it's my real honor to welcome Dr. Amir Hagos to Humanity Rising today. I've come to know Amir through work we've been doing together through the World Bank's Global Financing Facility on a project on transformative leadership, working with ministers of health, top civil servants, private sector representatives and representatives from donor and civil society organizations around how can people be, and governments and countries be better equipped to navigate times which are extremely challenging in terms of their complexity and the pace of change. And it's been remarkable for me to see how this World Bank program has stepped into really trying to find the leading edge practitioners, not just from the universities or schools one might traditionally expect, but who are really trying to find the new ways of doing things that are really fit for the times. And and during that program, I've come to get to know Amir fairly well. We've been exploring lots of different topics. I think we're kindred spirits in terms of our idea generation, and really come to know you, Amir, as someone with not only great brilliance but great humility at the same time, which is often a rare combination. So it's been a pleasure getting to know you, and somebody with great vision for the future, not just vision, plucked out of thin air, but vision grounded in real experience and a real context. So I'm very much looking forward to having this dialogue today. Welcome to Humanity Rising.
Thank you, Peter. Thank you for having me. It's a great pleasure.
You're very welcome. So what we thought we would do today is love Amir to tell us, to share his story of his journey to becoming the Minister of Health in Ethiopia, and then the experience of that and what that's taught him about the state of the world today, I guess how to deal with the kind of complexities that we're facing, and then a look into the future for, how would you see the what's needed to be done as we move forward and try to grapple with what are only going to be increasingly more complex challenges, and a number of the topics that we've been starting to explore together, including from one end of the spectrum, the use of traditional healthcare in an integrated approach to healthcare systems, and on almost another extreme, the use, for example, of the latest technology like blockchain to ensure that funding actually gets to the places we want it to go to. So spanning a very broad spectrum. But to start with, Amir, I'd love you just to share your story of your journey that, suddenly one day you found yourself Minister of Health in Ethiopia. But what was the journey to get there?
Thank you, Peter. I was born in Ethiopia, on the north parts of Ethiopia, we call it Bahar Dar, the town city, and raised just like any other children raised in Africa, in Ethiopia. And after I completed my high schools, I joined Addis Ababa University, the biggest university and the oldest university in Addis, in the capital city. And I studied medical medicines and graduated as a medical doctor. And at that time, there is still, but at that time, there was a severe shortage of physicians, just like any other African countries in Ethiopia. And the total number of yearly graduated medical doctors was from 200 to 300 a year for 100+ million population. So there was like some kinds of assignment that the government should have to done at that times to assign you in some places. That's just with a minimum year of services. And there was one big legislation that passed around our graduation is we unless otherwise you make some kinds of services in rural area and in different parts of the countries, you will not get your degree, or you will not get your diploma of as a medical doctor. That was a very controversial legislation that was passed at that time, but that was the only way, in my opinion, at that time the government can push the agenda to move forward. So I would like, as with my friends and colleagues, there was an opportunity to choose on different regions. At that time, Ethiopia had 9 regions in 2 cities. So I was with my friends, with 3 of my friends, that we decided to go to Oromia region, one of the largest regions in Ethiopia. And then in that, there was some kinds of induction training before we deployed, just to give some of the policy of that sector so that we understood what does that mean, because we just have freshly graduated medical doctors that we know more about clinical part, but we don't know much about the public health, the Ethiopian context and others. So at that time, there was like energies, all of us, four of us, that we want to change, we want to do something big. We don't know what, but we all want to do something big and something like that. We always say that we were very young. We were 25, 24. So we all want to say that we have to do something so that we can tell our kids like what kind of journey or adventure that we trying to do in like all that conversation. So at that time, the biggest challenge was it's very difficult for the government to deploy 4 physicians in one hospital because there are a lot of hospitals without any number of physicians. So it was difficult for any regional states president or anyone to assign us 4 of us at the same time. So that was a very difficult journey. But we all said that let us stick together. So let us give some kinds of option for Oromia Regional Health Bureau heads. And we said, you can assign us wherever the worst hospitals or in the very remote area, we are okay as far as you keep us, 4 of us together to be assigned in that places. So at that time, like since I was very like slim and like young, and we are still a very good friend of the regional health bureau heads right now. We work together after that. But at that time, when he told me retrospectively, he said, "This is very like tiny young physicians. Like why he's so much sure that he will make a change if I assigned him to that remote area." But with a lot of back and forth, they all agreed to send us to the southwest parts of Ethiopia that we never be. So we just went and we just assigned to the hospitals. And there was like around 126 professionals and administration staff in that specific hospitals. And that hospital served around 500,000, 600,000 populations in 3 or 4 districts. So we just went there and everyone has a lot of energy to do something else. So we tried to start slowly and trying to bring some changes with all that energy and everything that we have. At that time, the total number of budget, the yearly budget of that hospital is less than $75,000 with all 126 plus staffs and with 60 beds that we have to take care of all the 3 meals and drugs and everything for the patient. And also there was roughly around 100 to 150 outpatients that we used to see every day. So you can imagine 75,000, but that was the biggest, largest money that I am ever responsible for in my life when I went there. So I just became a medical director after 3 months. So that was like the biggest responsibility as a young person that I ever had. So I was so like energetic with all my friends. We wake up around 5 a.m. or 4 a.m. just to do and to see how things are going. It's just like we feel like the hospital, we go to some places. We don't trust that because that's the biggest responsibility that we had. And we go back to our room at around from 9 to 10 p.m. So at that time, the total, there was no electricity, there is no tap water, there is no network or telephone or everything. It's the most rural parts of the country. So we tried many things, but I just want to mention one that I really believe that's something that shaped my future career. We got like decent money on that specific area as a salary, even if that salary is less than $100 per month. But that was like decent in that area that we made a good amount of money. But there was one biggest challenge, like as there are a lot of our staffs that's being sick, but there was no staff insurance or there is no staff treatment package or anything. So whenever that the staff are getting sick, there was one paper that's turned around. You will just write your name and the amount of money that you want to contribute that, and you'll send that. Then that will be deducted from your salary. So every month, even if we have that like decent money in that area, $100, we never get anything because we signed many paper because there are a lot of people sick or colleagues or maybe even the citizens, the population in rural area, they'll just come and they don't have any money. There is no mechanisms to pay for their services. So we have to contribute every time. So it seems like become impossible even for us to survive with the amount of money that we will get because we just spend that with that contribution. So one day we always have a brainstorming session every day. So one day we all said, why not we have some kinds of brainstorming how we can solve these issues. Then we come up with why not we contribute some percentage of our salary to be put as some kinds of pool funds, and we will use that money to contribute for anyone who's getting sick. Then we all agreed, and we just allocated 1% of our salary as a pioneer. Then we convinced all the staffs, and everyone was happy because you can imagine, like, within 1% if you get all the treatment assets. So we started within that, and then we tried to come up with different innovative way of fund mobilization. Like we started some small coffee, as in Ethiopia is the origin of coffee. So the place that we want is actually the place that coffee originated. So originally fine. So that's a place that we want to sell some coffee and others. And then we try to come up with generator for power. And for the first time, we bring coffee machines in the history of that area. And we are the first to provide coffee and macchiato, coffee and milk. That was like a big thing. So we try to generate some resources with that, within 1% of our salary. We are pretty much doing good with treating all the staff that have some kinds of sickness or need treatment. But there was a request coming from the staff. They said, we are good that you are covering our insurance or some kinds of health expenses. But they said, what about our families? So, okay, we said, okay, we can do that, but we will not do that within 1% contribution. So let us make it 3% our contribution, and then just let us make it open for everyone. Then everyone agreed, and just we started that. Mind you, there is no regulation, there is nothing. We are just so passionate, and we want to make a change. And like right now, I know that it's impossible and illegal even to collect money without having some kinds of legal entity and background. But at that time, the sky is the limit. Like we all just want to do something big and something like to help, something like that. So we just produce some kinds of paper as a regulation by our own selves, and that's how we start. So, and we just open a bank account and just put the money there, and we are moving that kinds of activity. But there was a big trust between the staff, between us, and between the so 3%, then the whole families are get in. Then after that, the other government workers, teachers, people who work on agriculture offices, people who work on water and others, they all just came to the office and they said, what about us? You become getting some kind of insurance coverage. So why you just left us alone? Then we said, okay, just bring in, like, to contribute 3%, then we can just put you in. And then we all agreed to add more and more people, and it's become bigger and bigger, and the insurance package is also becoming stronger, and we get more money ahead of time to use that to improve our systems and others. So at that time,
Amir, just as somebody has asked if you could speak a little more slowly so they can
sorry.
Okay.
Okay, sorry, I'll try.
Okay.
You can imagine, like, this is how my energy is driving when I was working there. Yeah. So we all, at that time, there was some kind of initiative at the federal government level, at the Ministry of Health, try to see if Ethiopia is ready to do health insurance. And they were just discussing about that idea. So we, at that point, we were like shortage of cash to do big thinking that we have. We want to improve the hospital services. We want to upgrade our inpatient services and other, but we have a little bit of shortage of cash. So I, as a medical director, I was trying to mobilize more resources. So I have to communicate the district officials, zone, region, and federal. That's Ethiopian way of administration, how it works. So I have to went to all the way to the minister. At that time, the minister was Dr. Hagos, the current Director General of WHO. So I went to his office, and then I went to try to explain our vision and what we did. And he was so surprised that we already did the health insurance at the country level. So he was very happy to support us, but there was a problem to directly give finances from the federal to the hospital. Due to those challenges, we couldn't mobilize more resources to our hospital. Then it's sad. So we just went back to our hospitals and we called up another brainstorming sessions. And then we discussed and we said, why not we collect money from the people, because we already create that trust and we can mobilize resources within the population. And we start to kick off a telethon, mobilizing more resources at the country level. And that was the biggest turning point in my life, that, I never thought we made an impact on the peoples to really trust us. And the turnaround was very big, like around 100,000 people came in to that resource mobilization. And they all try to give us everything that they have, cash. Some of them give us cows, butter, coffee, everything that they have, because they really believe on the hospitals are improving and we're trying to get some sort of services. And we mobilize like 3 times the total budget of the hospitals.
Wow.
So we mobilize that much amount of money. And right now the hospitals are upgrading and everything's happening. So that was the place, that was the time that Minister of Health at that time, Dr. Tedros, and the regional president, they just keep an eye on us. And then, after we serve our time, we have to go to the specializations. And I was always...
Amir, just before you move on from the hospital, I remember you telling me something about where it was in the ranking of hospitals in Ethiopia and where it finished.
Yes.
By the time you were done.
Yeah,
Come on, you have to share that.
Thank you, Peter. When, as I was telling you earlier, when we asked the Oromia, the regional health bureau heads to assign us, to deploy us in one hospital, one thing that we promised him is to deploy us in the worst kinds of hospitals that no one wants to go, as far as he keep us, 4 of us together. So that was the background. So he just allowed us to went to the hospitals. That was, at that time, there were 40 hospitals. And the rank was the hospitals prior to our deployment was 40. And they were saying that there is some kind of joke. They said, if there is a place between 39 and 40 to make it a little bit down, they will make it happen, because the difference between the rank of the hospital with 39 and 40 is big. So there is no number lower than 39, that's 40. They told us that. That's why they put that hospital on 40. So within a year period of time, we were lucky and we become the first, and we get all the gifts and others, and we got 1 ambulance as appreciations for the hospitals.
Within a year, did you say within a year?
Yes, within a year.
From 40 from the bottom rank to the top rank.
Yes.
I mean, you guys were really, social entrepreneurs in that sense. You just kind of sat down, saw a need, and it must have been one of the first ever crowdfunding programs, done in Ethiopia. And then on top of that, it wasn't just money crowdfunding. People were giving whatever they could in terms of resources to help you make it happen. Amazing. An amazing story. Yeah. So no wonder that you caught the attention of people at the federal level, right?
Yeah, I'll keep slowing. Sorry.
Yeah, keep slowing down. Yeah.
Yeah.
Nancy.
So when I tried to join the specialization on the same university, Addis Ababa University Medical Faculty, I always want to be a surgeon. So that was my passion. So I just passed all the entrance exam and everything, and I start it's almost like at the initial phase to start my career as a clinician to become a surgeon. But at that time, the minister, Dr. Tedros, he challenged me. He told me that I am more a public health person rather than a clinician, but I really want to be a clinician. So it was a lot of back and forth. But finally, he convinced me, because he asked me, okay, you become a surgeon. You become like the finest surgeons in Ethiopia. So let us talk with you. He said, let us tell me how many number of people that you do surgery per day. You just put the number. We just multiplied that with week. Then we multiplied that with a year. Then we multiplied that with, if I am become active for 30 years, 30, we just multiplied that. We just find out a number. Then he just told me that's we just add the family number and some of the colleagues, the relatives, and we just have got some number. And he said, okay, this is the maximum number of people that you'll save in your whole life. So if you become a public health professional and come to the leadership with policies, with your thoughts, with everything that you have, you might save like 100 times or maybe 1,000 times that this is a number of population. That was the aha moment. Okay, that makes sense. Then I agreed to join public health. And at that time, I just start working with the public health, and not on Ministry of Health, but I just shift my postgrad from surgery to clinician to public health. And I just skip Addis Ababa University Public Health Institute to start my second degree master's program. Then after 6 months, my grade was good. So I just got scholarship on South Africa University of Western Cape. And I joined that schools and did my master's on public health, special focus on human resource development. And then I just go back. It was when I went to that schools, there was some kind of flexibility to stay at home in Addis sometimes, and then join the universities within some amount of time. So within that time, I was trying to help, even if that's free time that I should focus on my educations. I just want to do something. So I asked one of the zones that I was working with. The zone is like higher than the district, but lower than the region, with around 10 to 11 districts under it. So I started working with zone with multi-sectoral work, because I really believe health will not achieve anything by its own unless otherwise supported by other sectors. I always believe in comprehensive development, and not in sectoral kinds of development. I know there's a lot of academics papers about social determinant of health, but the problem is how we can bring all to make an impact at the lower level. So I was willing and volunteer to support the zonal administrations to bring some of multi-sectoral work to improve the life of children. So we just took some plot of land, we organized women who have kids but we don't have much money to do some kinds of agricultural activities. We brought something from the food institutes in federal level, high yield kinds of crops and others. And we try to connect that with education, we try to connect that with health, and we were trying to do such kinds of activities. And I joined the Ministry of Health as an officer. So when the first time I joined the Ministry of Health, one thing that strikes me a lot is, and we'll talk when we talk about blockchain, that will come about this finance, is I was so, like, it was a aha movement for me, because imagine the total budget that we have at the hospital is 75,000. And how much it was painful to count every penny to do any kind of innovation is difficult. But at the ministry, like all of the budgets, both the domestic and the overseas budget that's happening at the ministry level, I'm hearing numbers, like someone said, oh, this 3 million, 4 million, 5 million, you know, there are numbers. And they said, oh, this money, we couldn't finalize the project, so we have to return back the money to this organization, something like that. And at that time, I was thinking, if, like, the number that everyone mentioned was in Ethiopian birr. Currently $1 is around 45 Ethiopian birr. So imagine, like, at that time, I thought the numbers was in birr, and I was so shocked. This whole amount of money are just returning back to the donors or to the treasury, even if there is a lot to be done at the lower level. Then I figured out that they are talking in US dollar. I said, wow, like, this is because money that can make a biggest change if that goes to the lower level activities. Then, you know, we were discussing, and then I have much interest on human resource development. Then through times I become a case team coordinator, and then to become a director for human resource development. Then I become a director general for planning, financing, and resource mobilization. Then I become a deputy minister. At that time, I was the youngest minister to be assigned. I was 29, and then become a minister. So this is my journey in Ethiopia.
Wow. How old were you when you became minister?
When I became a minister, the deputy minister 29. When I became a minister, it's 30.
Wow. Yeah. Amazing. What an amazing journey. But and from the beginning, like, this understanding that this kind of artificial division into different areas like health, education, you know, and the way money is allocated is so contrary to actually the reality, right? Where all the different pieces are connected up, and yet we assign budgets and things to just education or just healthcare or just, I mean, that, you know, wasn't there, how did you deal with that as as minister, because you were already aware of that from your experience in the zones, right? That it was much more effective to somehow connect the dots rather than just work in this siloed way. Were you able to make an impact at all when you were minister in that area?
Kind of, not like as I imagined to be, but there is some kinds of something that we did when I was a minister was, as you know, there are, Peter, you know very well, these vertical programs that each development partners and any agencies that brought to the countries. Like some of them are disease specific, some of them are some kinds of idea or intervention specific, and every amount of support that we are getting as a country have its own plan, its own budget, its own leisure, its own report. So in a way, we spend like much of our time on planning, on writing a planning paper, and we should have to have two conversations with each donors because we are poor, and writing some proposals and also writing some reports. So much of our time, developing countries, the leaders and also the professionals are spent on such kinds of activity instead of the real job of making differences at the level. I know this is also important, but the amount of money is not really much to each other. So that was always complained, and we always tried to do some global movement to alignment, harmonization, and other activities. But we almost are like have a blind spot that I will speak for myself. I couldn't see we also do the same thing to district. For each district, each sectors have our own leisure, our own support. The health sectors, we only do planning and budgeting with the health department at the district level and regional level. And that support have money that the districts cannot use anything else except using that money for health, even if they have some other priorities. The same is true for 20 sectors that we have in Ethiopia. So we try to do brainstorming with my colleagues, ministers of 11 ministers from 20. We start discussing why not we thinking of really giving the districts a chance to find out and the problem and the challenge, and why not we support them without sectoral thinking to really make a big development at the lower level? Because there is no one who knows the biggest challenges of the district than the people who's living there and leading and working with the community. So after like 6 months or something like that, everyone seems like having some traction to try that activities. Then we piloted in 32 or 33 districts. What we did was we just said for each district, please bring the 3 most challenges that you faced without thinking in sectoral mind. Just open your mind, just bring the 3 most challenges that you see at the district level, and then we'll find a way to bring finances. And for us, we brought some kinds of virtual kinds of pool fund. So we all allocated money without any kind of demarcation. The money that we used to budget for that district, we just put it there on that basket without any kind of demarcation, so that the districts can use that money for the future. So one of the eye-opening movement for these 11 ministers was before we almost reached on this consensus, we made some tour to the most district and rural parts of the community. And at that time, we were, I think, 9 or 10 ministers. And the transport ministers was not part of that tour because we really didn't see transport as social determinant of health. And we didn't think that that's the biggest issue. So we went to one of the very remote areas, and we had a discussion with the community leaders and the community. At that time, one brilliant and very have a lot of wisdom, community leaders, he was telling us the challenges of the area and things like that. And we all give him names. We said that my name is Mr. X, and I'm a minister from this sector. I'm a minister from that sector. All of us. And there was no transport ministers from all of us. Then we asked him, if you have one challenge, one problem that it can be solved with, that would transform the whole village, what would it be? And he even couldn't think twice. He said, transport, road. And we were shocked because, most of the time, when you see people coming from some sectors, there's a tendency to ask them the challenge that's specific to that sectors, because those are the people. That village might not see any ministers maybe for the rest of that village time in the future, because there was no other ministers who visited that village in previous time. So it was like one time opportunity that they can say something to get something from that. But he just tell us the truth, like the transport, the road for that village was a priority. So that was the eye-opening moment for everyone to engage on this aspect. Then each districts can come up with 3 major challenges. We summarize those challenges, and it only fall on 4 sectors priorities. There was no health on that priority. That's not because health was not an issue on that district, but because they see health is a bit advanced, a bit forward, but there was no water, there's no food and others. So they already find out without food and water, availing health facility, it's not serve anyone. So that was the understanding, and we just put the money. The federal government convinced to give us 400 million Ethiopian birr at that time, and then we invested that aspect. And the final result of assessments of those districts just came, I think, 2 weeks back, and I was so happy. We managed to minimize stunting with 23% within 3 years period of time, because we changed our way of working from sectoral kinds of approach to multi-sectoral approach based on.
What did you say you were able to minimize?
Stunting, child stunting.
Oh, stunting, growth.
Yes.
You mean? Okay, they don't grow to their full potential. You managed to reduce that by.
Yes. As you know, Ethiopia is the highest stunting rate, one of the country with highest stunting. And as you know, stunting is not only related to food, but there is a lot that has happening. So stunting is a litmus paper for development. It's something that comes through time, and it's something that goes through time. It's not just something that you'll just fix it by bringing something else, just like wasting or marasmic or kwash. That is a children's disease later to malnutrition.
This is related. I think it sounds to me like what you're describing is related to a question Diana put in the chat about the focus being on prevention rather than cure. Because you're saying, okay, yes, we are in a way indirectly affecting people's health, but we're doing it by providing food, providing water, providing access to education, all of which, prevent people getting sick, essentially. Were you kind of very consciously working on prevention strategies as part of the kind of health plan, as it were?
Absolutely. The motto, the philosophy, and everything of Ethiopian health sector and system is focusing on prevention. And we got much of criticism that we are not focusing on curative services, like as a country. And especially with this COVID, the criticism becoming more and more, because people want to get more care in hospital rather than focusing on prevention. And that's always curative. We have to do both, but in developing countries, we have to do like 70-80% of our time, money, investment in everything, in my opinion, should have to be invested on prevention rather than curative. So that's absolutely the way that the whole philosophy, policies, documents, strategy are developed in Ethiopia. At the same time, that was the thinking behind when we established this multi-sectoral district transformation idea to support the district better. To give you one concrete example, Peter, when those plans from 33 or 32 districts came to our office, as I said earlier, there was no health investment. There was no health center building, or there was no medical or any kinds of activity from the 3 major challenges that they select each district. So you can imagine it's very tough for the health sector to give money without doing anything on health. And that was the biggest challenge that I faced from my management at that time as a minister. So everyone said, look, you are giving much money for that district. There is a lot of problem in health. There is a lot of problem in health. So how can we just give our money to invest it on other sectors while we have a lot of problem on health? So that was the biggest challenge I also had. So I was trying to say, Like I was telling them on different evidences. For example, at that time there was DHS, that's already done. District health survey, demographic surveys is already done, and it shows that both all services, immunization, family planning, and every services have some kinds of stratifications based on educations and also based on rich and poor and other activities. So just to give you the educations only examples, the family planning, the immunization in every services is increasing when the mother literacy level are increasing from illiterate to become like completed grade 4, completed grade 12, have some kinds of college degrees or advanced. So it is the same kinds of people that's living in the same area, but with only working on education will increase the services more than 60 to 70%. So I said, look, like as health sectors, it might be efficient if we spend much of our time even supporting the education rather than working on health. If you really want to improve the indicators, the intervention, if you really want to change the people's lives, that's one. Second, we have health facilities in those districts. Most of them doesn't have power. Most of them doesn't have water sources. So what kinds of services we can provide with those health centers, unless otherwise we invest on water and power sources? That's second. And third, with that health facilities that we have, with no power and no water, there's already 50% or 60% of the service already compromised. But even within that, most of the patients that we are seeing are people who can be prevented if they got water access, food access from the beginning. So it's a vicious circle. Like unless otherwise we go and solve that vicious circles, it's only doing job for the sake of job, for the sake of we saying that I have something to do every day. So that, yes, to make it very short, yes, we really believe on preventions, and I really believe that should be the way forward for developing countries and also developing countries.
It sounds so obvious, doesn't it? When you talk about it, that to think not in these boxes that we put everything into, but to really look at the issues and work out, okay, what's really going to make the impact, rather than allocating budget to these silos and then insisting that they get spent on that silo. And it's just part of, I think, this a Western mindset that's been exported as part of the development paradigm, together with, of course, all the money around how you then need to structure your governance in order to be able to receive our money that came with it. I mean, it's crazy, but it's lovely to hear your story. That it's kind of common sense, really, isn't it? But,
yes.
But it's so hard to. But it's weird that it's so hard to be able to practice common sense, in these kind of structures. Let's before we move on from your time as minister, just one last question. What would you say your greatest learning was as a minister of health?
I think like my greatest learning as a minister and also working as government workers, from the medical directors, from the medical doctor clinician up to the minister level, there were like a turning point in my life that I saw how much you can do little to get all the blessings of the community. And that was a big turning point in my life. I promised to myself that the rest of my life, I will do everything that I can. At first, not to harm the community on everything that I'm doing. And if I can, to support as much as I can, regardless of where I am, regardless of doing, regardless of the positions or anywhere that I be. Because from my first experience as a physician in that very district area, with like different languages that I'm speaking, as you know, in Ethiopia, we have more than 80 language and cultures. So even if with all that, that was not a problem to connect with peoples who don't speak my language and I don't speak their language, but it didn't really made us any kinds of disconnect. And they gave us everything that they have when we requested them, even if we only give them a little, but that gives them an inspiration to do everything that it takes to improve their way of living, to improve their livelihood, others. So that was the biggest lesson in my life, and I will never forget it. I'll always tell my kids and continue telling them like how much it's a blessing to get a chance to serve the community that's in need.
Beautiful. And that's, I mean, in a way, that's the people in the community who you become your greatest resource then, right?
Yes.
Yeah. Wow. Now, you were minister for 2 years, right? And you left under circumstances that you wouldn't have chosen. I think, are you happy to share those circumstances, that journey?
A bit, yeah, partial of it, maybe. Not the whole story, not because I don't want to share, but because
No,
of
but just
some
part.
of the,
It's
yes.
a human story, you know. It's a human story, and
yes, the human part. You know, as a minister, I was so happy working as much as I can, but I always have also. I always keep reminding myself that this place needs much knowledgeful, experienced and educated person, because we are talking about 120 million populations of Ethiopia. And we're thinking about a person who is in a way in charge of the whole health sector with their colleagues and others. So I always say that what's my advantage, kind of like that give me to stay in these places. It's not because of that someone assigned me as a minister, but there should be some kinds of comparative advantage that I can go to that places. So the only thing that always keeps me going every day with all my energy, passions, that's the only thing that keeps me going, that, okay, I might do something for that position, even if it deserves more than myself, is because of my thinking that I can decide. Like I will not hesitate. I will just make decisive when the time comes, when the decision is really needed. I will not give like much thoughts for a month, 2 months. But if that's something that can be benefited, I will do everything it takes with all the risks. So that was the movement that always kept me going. And I'm very happy with every time that I served as the ministers. But from time to time, it's become a bit of hostile, especially on the ethnic tension and everything that's happening at the country level. It's become a big hostile. I was okay with that because that was the risk that I wanted to take. But through times, it's become difficult for my families too. It goes to beyond my risk goes to beyond mine. It goes to the family, and I'm just trying to keep them within that risk and working with them because they are very supportive. My wife and my kids, everyone was supportive, but the time came that it's become almost impossible for me to continue within that very difficult environment because of the political tensions and ethnic, some kinds of toxicity that's happening at the country level. So then I just decided to resign, and everyone, colleagues, was supportive, and my resignation accepted after a while. Then I just left.
Yeah. tough world, politics. And you, so you moved to the US when you left?
Yes, yeah. I joined the Susan Thompson Buffett Foundation as a senior government advisor, and then now I'm working at Global Finance Facility, World Bank, as a senior advisor.
Yeah, and in that role, we've had some very interesting conversations on a couple of topics related really to also how you see the future. And it's funny because some of these conversations about the future are also very much about the past and the reintegration of the past. One of the topics that I think would be particularly interesting for people to hear more about is this question of the traditional healthcare and the role of traditional healthcare, because often in the modern is seen as Western, healthcare services, and the traditional sector is seen as backward, essentially, or primitive, or, and yet and I'm gonna cite this number, so you don't have to, but you've told me 87% of the population would go first to a traditional healer before they go to Western practitioners. So talk to us a little bit about how you see the relationship between Western science and indigenous science, or Western medicine and the traditional medicine, and what the potential is of actually working collaboratively with that traditional healthcare sector.
Thank you, Peter. Maybe I'll start from mentioning the opportunity for the traditional medicines in Africa in general and in Ethiopia specifically, and also how that can have a complementarity role with the Western medicine, but ideally, but also to mention some of the practical things that's happening, as you mentioned, like it's always considered modern medicine as modern and traditional medicine as primitive or backward. So how much that affect the whole landscapes and health structures at a country level, at a developing country level. So to start with the first point I mentioned, in many of the countries in Africa, first there is a huge opportunity on biodiversity that's already there for traditional medicine. That's one. Second, there is already a culture using those traditional medicine for thousands of years. And there is already some knowledge and development within that time about this traditional medicine. And as you mentioned, Peter, like more than 87% of the population, regardless of their educational background, whether literate, illiterate, or whether they are poor or sick, including whether they're physician or not, the first entry point is traditional medicines. It might be at home, maybe at the healing centers, or at least more than 7% of Ethiopian population, the first entry is traditional medicine, then they will go to some medicine. So this will tell you how much the culture and the practice is already there in those countries. So this is the potential, the opportunity that we have in many countries, including Ethiopia. And I really believe there is a synergy that we can utilize, and we can use complementarity between Western medicine and traditional medicine, because there are some activities, there are some knowledge and practice that traditional medicine has that lack in Western medicine. They're also the same, that there are some activities and interventions that the Western medicine have that lack of traditional medicine. There's also something that they can work together. So there is a lot of opportunity to synergize. Then I'll come to the reality. In real world right now, because of all different issues, including that those countries who have reached on traditional medicines, culture, and activities are poor, and those who have support resources and money have more advanced on Western medicine, there is always a pressure, a perspective that can push the country to focus more on Western medicine. That's the biggest push. That's one. And second, due to like these modernizations, and due to everyone want to become on modern side, and there is already some kinds of level traditional medicine as backward or something like that. That's also some kinds of in a pull at the country level that can also push this traditional medicine out of the picture and to focus more on the Western medicine. So that has a biggest effect. And most of the people, and most of the time, we only see the direct effects of Western medicine on traditional medicine, on drug-wise or service-wise, like how much many traditional herbs are just almost wiped through from the countries and just almost disappear from time to time. How much like many kinds of animal products that can help us to improve the health service, the sickness and the morbidity of the communities already almost at the extinction stage in many of the countries. And almost some of them are already extinct through time. So that is the biggest loss. But for me, it's beyond that. For me, the damage is beyond that. And if you really know how to play it well, the advantage is also beyond that. It's more synergized. For me, this cultural background that have really are moved from the country level. Those cultures that use traditional medicines and everything will help us as a foundation to use as a springboard to include some of the Western services to move way forward. But we try to create a new wheel by really abandoning and moving every wisdom and knowledge that we have on traditional medicine as a way forward. Let us give you one example about health professionals. In much of developing countries, one of the biggest challenge is the ethics, the quality, the compassion, the care that the health professionals provided to the community. In many places, there is a lot of feeling from the communities that they are not getting the service that they need because of the professionals might not attend the clinical services due to different reasons, and the way that they are providing services is not as per the needs of the communities, the care and the compassion and everything is becoming less and less through times, and there are many reasons. And I know that there is a lot of reasons from the health professional side, like the bureaucracy, the politics, the incentive, there are a lot. But still, within that scenario, there is something that we can do. And I'll tell you one of my experiences on that. As a ministers, we are working on many aspects. One of the priorities that we want to solve is how we can work with health professionals to bring compassionate, caring, and respectful health professionals to providing the quality health care to the community. So we try to do a tour to many places of the world, Eastern, Western, South, and the North, to bring some experiences, how other countries are doing such kinds of professionalisms on different aspects. And we did a tour to many places. We bring all the experiences, paper, and we try to write something, and we try to apply that. But we didn't get that much outputs, even if there is some change, but it's very minimal change. Then we were very frustrated, and we were lucky to find out one very wise person, and he asked us that what we want to achieve, and we just explained to him everything. And that person said, but there is a place in Ethiopia that you can get those services that you mentioned, the best services with health professionals. And we said, no way, that's our challenge. And we want to bring that change to the country. Said, no, there is. So just try to go and see what kind of services that's provided on traditional healers. So it's not the quality of the service or that whether it's healing purpose or not, but it's the whole system service. And we said, wow, so that's right, because every one of us, including me, when I was a kid, even as an adult, I was taken by my mom to the traditional healers to get some services when I was sick. So the best services in our mind is a service that the patients will not think whether they will get the care or not. The service that they will just go and get all the respect, compassion, and everything that they will get. The service that they will not think about money, whether they have money or not to go to services. The services that they will not told that after getting services that there is no drug or there is no laboratory, all that aspect. So he's right. We already saw all that at traditional healers. When our mothers or fathers take us to those services, they will not even think twice whether that person's traditional healers will be there or not. He always be there. And they will not even care about finances because they will accept whatever that they have. That's healthcare financing in modern code. And they will give services. And if they don't have money, they will get services and they might pay some time or something like that. And there is no worries about how cultural sensitive that traditional healers, the respect, the compassion, and everything. Even they provide them coffee and some food if they are not eating, in addition to the services. And there is no thinking about the supply systems. They really managed to avail all the drugs that they have through this difficult environment with the very amazing supply systems that we fail to bring even some simple drug to the rural area, but they managed to do their supply systems all over the country. That's similar in many African countries. So that was wow, movements, there is already there. And in my thinking, the health services of developing country are trapped in between of the biggest wisdomful and culture that we have at the past and the modern medicine that we want to move. So we are trapped in between. So let us go to health professionals. Our health professionals, they are not becoming like all the community wants because of there is no like strong institutions to make sure that there's a professionalism ethics and others just like the West. So we don't have that. And we also lost, because of we think it's backward and something like that, the genuine pragmatic kinds of culture that we have as human to provide all the services that we need for the community, because we think that's backward and we just move to like the Western world. So we are trapped, and I think we need more kinds of thinking and just reflect to ourselves how we can use all that already existing culture without it's extincting for good to bring to modern medicines and to come up with a powerful way forward to give more services.
Well, it's a fascinating topic that touches, I think, some really important themes. Generally, I mean, when you describe how, let's say, the Western mindset is being imported, it's almost like a new kind of colonialism, but not so much with the military might now, but more with the money and the science at one level. And one of the, so somebody mentioned in the chat, they obviously each approach has bits that they can add, but the traditional approach tends to take a more holistic view of the person, let's say. And whereas the Western, and I was at the dentist this afternoon, so I have a direct experience of feeling like a car with about 1 million spanners in its mouth, at the same time. I was like being treated as a machine, where it's you go into the specific pieces, everything's divided into parts and it loses track of the picture of the whole. But one of the things we've been exploring in terms of how we might bridge this is how some of the more recent science in the West is starting to show the holistic nature of reality rather than the separate nature of reality that kind of science traditionally has focused on. And the example I often give is the 28 years of research at Princeton University, where they proved beyond statistical doubt that human intention and our inner state affects the world around us, and that we can pick up information outside of space and time, seemingly things that can't be explained by the normal kind of scientific paradigm. Or the research done at IONS around how, healing, what goes on when healers do work with a patient, and what they can actually track the process and do it following Western scientific norms. I mean, the challenge, of course, is still whether somebody's mindset is open enough to be able to accept that that's a possibility. I remember Bob Yan, who was one of the people at Princeton, saying, a so-called scientist came up to him and said, "Look, Bob, even if what you are saying is true, I wouldn't believe it." And he's kind of, well, that's not science, that's dogmatism, essentially. And so it's one of the, if as quickly as possible, it feels like we need to find a way to bridge this gap and create a story that, for the Western mind that's open to it, shows that there is actually research showing how these approaches, whether they are the kind of more physical approaches with the herbal solutions that people find locally, or whether they are more the energetic kind of distance, non-touch healing approaches, or healing that happens through ritual. All of these things have been researched and shown that they work and why they work. Because my fear is that in a way it's a question of diversity, in the same way that we're losing the biodiversity, that actually is providing the resources for these healers. We're losing the cultural diversity that's being stamped out, because in a way it's at one level it's a threat to profits. It's like, well, if people can just go to the local healer and find their solution, why should they go and buy the drug from the pharmaceutical company or whatever? So there are all these different interests at play that are kind of squeezing out these more indigenous practices. And I was shocked, to hear from, we were on a call with Apila, Colorado, some of her stories of what she's seen happen to traditional healers. That I often tell the story of the witch trials and the witch burnings in Europe, hundreds of years ago. It sounded very similar, that's still going on, but there's still, in a way, a persecution of the perspective that is like, well, you don't have to go through the expert. You can actually, we can help you access this healing power yourself at one level. So it's feels like it's a really important challenge, but one that is also going to be, fraught with resistance and all sorts of interests that may not be so happy to concede ground, let's say.
Absolutely, Peter. That I always say that the biggest reward comes after the biggest challenge. So if we really want to bring a biggest impact and change to the community, I think traditional medicine, holistic traditional medicine, not the transactional drug only activity, but the holistic one will make a big difference because of many reasons. The world are right now talking about equity, to have equitably distributed health services. Traditional medicine is already there. It's only about working with them and to boost some of the activities. Quality, if there is already room for improvement. There is already some services, both psychological and some kinds of medicine kinds of activities happening there. Finance, the most cheap way of giving services is traditional medicine. So there is a lot that we can learn. But I would conclude my point on traditional medicine. The biggest things that we can learn from traditional medicine, traditional healers, is in contrast to Western medicine, as you mentioned, Peter. In traditional medicine, they treat the person. In Western medicine, they treat disease. So for Western medicine, if I just went to services with malaria, everything that the systems look at me is just like malaria. Just malaria. I'm malaria for that. The whole systems, from the registrations up to the final stage, I'm malaria. Even like there is a name on cases, you'll not even mention by name. You say that malaria case, like TB case or cancer case or HIV case. So wow. There is no human behind it. That's why there is no that compassion, respect, and caring are difficulties to bring come through because I am a disease. But for traditional healer, I am human. Wherever that I am going. So they are trying, I am human with some kinds of sickness or some problems. So they will treat you as human. That's why all the supports that's comes through, that we can learn a lot from that. And I really believe our communities in Ethiopia, in Africa, they really deserve high kinds of services. And we have to challenge to bring such kinds of things.
Yeah, and I think the biggest learning of this for the Western mind will be to relearn interconnectedness and holism, because we've somehow, although we had that experience in our distant past, we somehow forgotten that we're all interconnected. We've forgotten the relationship between things. And in my opinion, that's why we've been able to do what we've done to the earth and to each other over the last, couple of 100 years. Because if we hadn't forgotten that we were interconnected, how on earth could we ever have treated the planet and the rest of life, on the earth like that? So if the Western mind can put itself back together again, remember the nature of interconnectedness through learning how these traditional methods actually are effective, then that would be a great gift, as it were, I think, to humanity as a whole, and hopefully, allow us to hang around a little bit longer than we're currently on the trajectory to. Right, let's pick one more topic then, which I know you're passionate about as well, which is about getting resources, to the people who should be receiving them, essentially the healthcare practitioners on the ground. And you shared another shocking statistic with me, which was of the resources that that are allocated from a donor to a country, only about 5% of those resources actually end up getting through to the beneficiary. And as part of that, we've been exploring, so, how could blockchain, as an example, be used to ensure that resources, that you skip out all those middle parties essentially, and that resources really do end up somewhere. And as part of that, you've talked about this concept of health as a commodity, which I was unsure of first until you think about it. Is health a commodity, something you own? So your health is something you own, and that was that kind of changed my perspective on it as well. So I'd love you to talk a little bit about that, this question of financing, and the kind of financing that's needed for the future that would have positive impact.
Thank you, Peter. That's an interesting topic. That's something that's close to my heart because of my experiences and from seeing the global health perspective from where I am right now. Remember, like the stories that I told you when I was in that very remote district hospital. I saw a lot of energy, motivation, innovations, and everything, but resource is very much limited. The whole hospital is running with 75,000. So I told you that story. So that's always give me like some kinds of discomfort that how we can change that. We have thousands of professionals in Africa that assigned youngsters with the same and more than the energy that I had when I was graduated, with a lot of passions, but there is no much resources to use to those innovations at the lower level, because everything is rigid and it's planned in a way that at the higher to lower level, and there is no places for that innovations and entrepreneurship and others. So that's one challenge that's always keep in my mind to figure it out and to find a solution for that. That's one. And second is, as you mentioned, Peter, the middle administrations amount of money, resources spent in between the donor or the giver and the recipient, and then the final beneficiary is huge due to different reasons, because we need people to administrate that, we need finance, we need, there is a lot of issues. So how can we minimize that, both in terms of money, in terms of time and efficiencies? These are the two questions that was in my mind, that how we can solve that. So this blockchain technology bring something that we still are trying to figure it out, but something that I really believe it might help for developing countries to proceed. So to do that, one of the big perspective change, as you mentioned, Peter, is how we can see health as a commodity that to be produced and also to be available for the market, to be sold, to bring more money to produce more. So that's a concept that can be blended with this blockchain technology. I'm thinking will bring the biggest difference. So with the conventional way of doing business, there is domestic finance for a country. They will just mobilize resources to allocate budget for the health facility. The health facility will give services and try to keep the community health. That's the conventional way. And donors will use different agencies in the government, in the private sector, and civil societies to channel their money to support the country better. So this is the process. And most of the time, we are using an inputs to produce, to give health services. Like we use the money to build health facility, we use the money to train health professionals, we use the money to bring drugs, and then we provide the services, immunization, delivery, family planning, or all the services to the future. So that's happening. But now, what if we can use all the services to be on the market so that people can buy? Because this conventional way of business, it has an issue with decentralized money to the health facility so that they can do better. That's one. It has an issue with many middlemen, but also it's not really become comprehensive enough to create a platform for peoples all over the world. I will give two examples. One is that right now we have many millionaires, billionaires all over the world who have money, but who don't have patience, per se, like to build the systems. They are result driven. They really want a result to see a result if they want to invest the money. But there are many good people who want to contribute on the better health of the people, but they don't have a trust for that. So that's one audience that I'm thinking of. Second is there are many ordinary people like you, me, Peter, that want to contribute a bit, but who don't have a trust on the government systems or the government, because we really don't see our $100 or $50 or $10 will go to the most needed children in the most remote area of African or developing country. So we don't have the trust. Or we also don't trust this big agency because the money with the $10 that we are contributing will not go to those places, but in between it is just absorbed through the administration issue. So let us merge these two audiences. If we can create a market that's already verified, that's already easily can be traceable, and if we can avail any health product like immunizations to the market, let's say one health facility in a very remote area of Africa has immunized 100 children per year. That 100 immunized children will have certificate or token or some kinds of digital kinds of activity to make sure that that's really happening and will not be duplicated and will not be counterfeited or something like that. Then with this blockchain technology, we will avail that certificate or token to the market with $10 per children to get that result, so that the money go directly to the health facility to produce more results, to immunize more children. So we can have a direct interactions between health facility and people who want to help and support. And at the same time, we can also incentivize and create a platform for the health facility for more innovation, more work, and more kinds of.
So in that model, you're paying for something that's already happened. So you know that your money is going to that, right? Because it's already happened. Yeah.
Yes.
Which builds the trust issue you were saying, people unsure how their money is being spent, etc. But in this case, it's spent on that. Yeah, nice one. Well, we're coming towards the end of our time, Amir. Before we hand back to Jim, I'd love just to give you the chance. Anything like if you look forward to this question of health into the future, just sketch for us a little bit your vision of how you would like it to be. What do you see as being the ideal kind of world? And then we say health, but then of course from your perspective it covers many things. But do you hold a picture in your mind of this is where I would like things to end up?
There are many dimensions within it, but Peter, I'll be very brief. Within 1 minute, I'll try to talk only about, in my opinion, the heart of it is about country ownership. So I hope we'll see it soon on health services that can be provided at developing countries, African countries, that's fully owned by countries. That means that the country will be on the driver's seat, not only on the driver's seat, but also the person who sits beside the driver who shows the directions also of the country. So that it will be a game changer for all the service structure if there is a health service owned by a country, not with people who have money. Thank you.
So people might be kind of surprised to hear, what do you mean the country doesn't, you're suggesting the country doesn't own it, but what you're saying is that because of the amount of money that's given to countries, it's the donors often set the agenda for the country's healthcare system without necessarily really understanding the issues, right? And
absolutely.
It really needs to be the country who has the ownership of that and not the funding institution. Yeah, great. Big one to crack, but we're on it, aren't we? Great. Thank you so much, Amir, for your time, for sharing your story and your inspiration. There's so much wisdom there. I hope that people either listening now or into the future will be able to draw inspiration and ideas from it. And do get in touch with us if you do have, if you're working in a context that's similar and you can see potential connections there. It's been great.
Thank you, Peter. Thanks so much.
Thank you for being so open. Jim, back to you, sir.
Thank you, Peter, and thank you, Amir. I am struck by your eloquence and your deep compassion for the vulnerable. And, you know, the point that you're making about the politics of medicine and health is a worthy subject. I would love maybe sometime to have you back on this. You know, if you think about it, for example, in the United States, it was actually John Rockefeller, J.D. Rockefeller, the founder of Standard Oil, that when he realized that he had a monopoly on oil, and he was the world's first billionaire, that he went after traditional medicine and had a concerted attempt that's now, 150 years in the development to disparage and marginalize traditional medicine, because most of modern medicine is based on petroleum. And there's a real history and a number of books that I would recommend to all of you to look at, to learn about how the oil industry and then the pharmaceutical industry has gone after traditional medicine vociferously in the United States and Europe, but also worldwide. And then when you factor in the agendas of the international lending agencies, the World Bank, the IMF, the WTO, et cetera, that leverage these philosophies through their international giving and loans and so forth and so on. The complexities of the politics of medicine. We're seeing it playing out right now with COVID. What is every government in the world and the World Health Organization saying? Get vaccinated, get vaccinated. There's not been a single government anywhere that has said, well, should we look at this holistically? Should we look at potentially traditional responses? Should we look, for example, at how people can increase their immune responses through diet, through exercise, through meditation? And part of the resistance to the vaccinations is not resistance to the vaccinations, but resistance to a whole mechanized conglomerate and way of looking at the world that is treating human beings as products for the pharmaceutical industry, rather than whole beings that need to be empowered as much from the inside out as the outside in. So, Dr. Hagos, the fact that you lasted for 2 years is actually a major testament to your genius, because you were obviously coming in with a completely compassionate heart. So I just want to honor that. And I don't know, in the few minutes we've got left, would you like to make a comment on what I just said, or Peter, because you're touching on an issue that is at the heart of how humanity wants to continue to evolve. Are we going to rely on high tech and big pharma? Or are we going to blend the best of Western science and technology with the most ancient science and technology, so that we can fashion an integral healthcare system and a medicinal system that combines the genius and the contributions of both? That's really at the heart of the discussions around the pandemic. And until today, day 283 on Humanity Rising, we have not had this discussion. So Peter and Amir, I just want to acknowledge that and thank you for it. But Dr. Hagos, maybe you could have the last word.
Thank you, Jim. That's right. That's the biggest challenge that the country should have to tackle, especially countries from. I'm always passionate about African countries because that's the most needed, and that's the countries that's the most needed on healthcare and development. So I really believe those are the countries who already have rich, ancient cultural experiences, knowledge, and wisdom that they should have to fight how they can blend it with modern, especially for health medicine, to move forward. So if the country is not on it, no one will fight their battle. We can only support them. So I'm very optimistic with all the support, Jim, you, Peter, and all the people who are here, and also others. If we can create the platform for more advocacy, more knowledge, to bring more leaders at the country levels to tackle these agendas, I think we can really make a big difference. But we need countries to stand for their own right and path. Thank you.
Thank you. And Peter, I think it would be worth closing out with a little description of what you're developing with APILA and the meeting in Chartres and so forth, because I think that's an indication, everyone, that Ubiquity is really getting engaged in this development of traditional medicine with Western science.
Yeah, well, I mean, when Amir and I were discussing this, I was thinking who would be somebody who could potentially partner in this, and it was just one of those things that dropped into my mind as I remembered the title of Apila Colorado's organization, which is the World Indigenous Science Network. And I was kind of, hey, she's bridging the world. So I reached out to Apila and we had a wonderful, very powerful conversation with Apila, as you might imagine, who's actually worked with traditional healers in Ethiopia and directly had a strong, and been arrested for doing it as well. So she's seen both sides of the coin, and has really got a sense that this is indeed a key issue. But she also said something that really stuck with me, which is, she said one of her teachers said to her that if you make an intervention at the center of a system, it ripples out far more effectively across the system as a whole. And she said, Ethiopia is the cradle of civilization. If we do this in Ethiopia, it will echo out across the whole of human civilization. And so I was like, okay, here we go. So yeah, indeed, we're going to be meeting hopefully in Chartres in September, a few of us to really actually, start to make this happen.
Yeah, and I look forward to being there as well. But you're doing God's work, Amir, and I just want to acknowledge it and salute you and thank you for everything you're doing. And I look forward to meeting you in September. As it turns out, our very next session on Monday is with Apila Colorado. She, among other things, has been a curator of our dream work, one of the most ancient and universal ways of healing is through our dreams. And one of the phenomena that has arisen during the pandemic that's been noted by scientists around the world is that people's dreams, since the pandemic has begun, have become more lucid, more dramatic. And Apila, who's been curating the university's dream team for 16 years in Chartres in France, where we meet every year for our mystery school, what we call the Chartres Academy, where we study the 7 ancient liberal arts, has been developing a dream technology based on the indigenous mind. Since the pandemic begun, Apila's team has been collecting dreams. And on Monday, all of you are going to have an opportunity to hear from Apila and also to talk about and report on your dreams. So if you're a dreamer, get busy this weekend and we'll hear from as many of you as we possibly can on Monday. And then we'll be reporting out the findings of our dreams during our course on the second liberal art, July 4th through 10th, which is virtual and online, which you're all welcome to, but Apila's Dream Group will be making her final report. So that's going to be on Monday on Humanity Rising, the efficacy of dreams in a time of pandemic. So thank you, Peter. Thank you, Amir. And thank you all. We'll see you again on Monday, same time, same station. And now you're all welcome to join our after session chat group. You'll see the link in the chat box. Have a good weekend. Bye for now.